Hello, welcome to CareTalk, a healthcare podcast. We bring you expert insights on treatment, recovery, and complete patient care. I am Robin, and today we have a very special guest here. Uh, Joining us, Dr. Harsha Narayanamurthy, a UK trained adult and pediatric neurosurgeon from Kauvery Hospital, specializing in brain tumor surgery, spine surgery, and peripheral nerve treatments. Doctor, thank you so much for joining us today.
You're very welcome. I'm pleased to be here.
Okay. To start with, doctor, could you share your journey into neurosurgery and what inspired you to specialize in brain, spine, and nerve conditions?
Okay, well, it's a bit of a long and involved story, but I'll cut it short for the sake of interest. I qualified in medicine from MS Ramaiah Medical College a long time ago now, 2002. Okay. And then I worked for, you might have all known the name Dr. Ravi Martan Varma, RM Varma, who was a famous neurosurgeon in Imhans. And I had the opportunity to work with him and his son, Dr. R.G. Varma, and they encouraged me to pick up neurosurgery as a career. But Dr. R.M. Varma actually made a very sort of new suggestion for me at that time to go to the UK and get trained, because he had worked in Bristol for a while, and he said if you can actually go there. So I decided to give it a try. So headed off to the UK with no firm plan. Luckily, things worked out. I managed to work in some wonderful places, meet some wonderful colleagues and trainers. And I trained, as it happens, in Bristol and Plymouth, and worked as a consultant in a couple of places like Nottingham and Leeds. Yeah, so that is the story in short. And along the way, at some point while training in neurosurgery, I realized I think overall my interest is neuro-oncology and tumor surgery overall, with specific focus on brain tumors and spinal cord tumors. And I have done fellowships dealing with these. And as a consultant, I dealt a lot with pediatric brain tumors as well. So again, that was very fascinating, completely different to adult neurosurgery, but yeah, fascinating nevertheless. That is how it all came together.
So good to know that. And I think you had worked in UK for pretty much of your time, and I think it has influenced your treatment plans and everything. So when it comes to India, how UK experience has influenced the treatment part in India also?
Oh, it's a rather good question. I think the United Kingdom, things they do well, I mean, obviously there are things that they can try and work on as well, but things they do really well is having protocols and good guidelines for most conditions that are common, things that are a big burden on society, the large-scale public health problems. They have a really good protocol for most of them, and that includes neurosurgery as well. So we have protocolized practice. There is subspecialization in aspects of neurosurgery, and that allows people to gain a lot of experience in a short duration of time in specific things they're interested in, rather than trying to be a generalist and focusing on everything at once. And they also have this concept of a multidisciplinary team kind of working, which I think India is now beginning to acquire. I think there's a lot of people who wish to work in large teams rather than as silos, individual practitioners. And I think that's a really good thing. So for me, coming back to India, I think there are some aspects that I can get here, which is the multidisciplinary aspect to it. We're already beginning to work on that in Kauvery. We've established collaboration with our 3 branches, and we are beginning to talk about subspecialization and referring within our hospital group to the experts in that particular thing. So I think it's all coming together. And then obviously we have to tailor that to the cultural expectations of our people. I think that's really important, trying to have an amalgamation.
That's good to know that India also coming into that level of treatment with multidisciplinary approach and getting the treatment into a broad spectrum.
Yeah.
Doctor, when it comes to a secondary thing like brain tumors, because when we say about brain tumors, most of them, they'll have a fear and uncertainty, like when a brain tumor or something happens, what will happen next? And one from your experience, like what are your latest advancement in brain tumor surgery, and what are the treatments advancement in the tumor therapies and the
Sure. So I think, as you rightly said, being diagnosed with brain tumor is a life-changing thing. Nobody wants to be told something's wrong with their brain. It seems to provoke more fear when it's something to do with the brain than anywhere else. I honestly don't know why, but then still, it does do that. The important thing to remember is we deal with it just the same as any other part, which is by careful planning, counseling the patient, discussing the ins and outs of the diagnosis, reassuring them, and then planning the operation in a meticulous way. I think there is one thing that distinguishes neurosurgery not above, really, that's wrong. It makes it different to other specialties, which is the thing about disability. Okay, so because we have the disability, our surgeries are precisely planned and delivered with a lot of precision. And with that in mind, the advancements are mostly to do with improving the accuracy of entry and exit into the brain. So you have neuronavigation, which uses a lot of complex technology to allow us to create a path through the brain, which will minimize damage to brain tissue and nerve tissue. There are advances in visualizing the tumor using scans in 3D, using augmented reality and virtual reality. There are techniques to map the brain during an operation, monitoring the signals, the electric signals in the brain. I think there are lots of tremendously exciting developments happening all at the same time, and it's wonderful. It improves the quality of surgery. Yeah.
Oh, that's a good thing. Like that means technology, what the improvement in the technology has improved the precision and the safety in the surgeries, correct?
Absolutely correct. Yeah, absolutely.
Yeah. So, are minimally invasive surgeries and or navigation guided surgeries are common nowadays, or it is rarely used in the field of surgery?
So again, I think that would be a bit of a nuanced and layered answer. If you look at the Western countries, for example, where I work, the United Kingdom, we certainly did have a lot of technological aids. Neuronavigation was very common. Any brain tumor operation, the standard of treatment was to use neuronavigation without a doubt. We used to do some advanced planning. We used to map the nerve tracts in the brain using virtual reality, and then we could easily do a virtual operation before doing the actual operation.
So that means to say that somebody from a different country is operating in a different country because the technology has developed.
No, you're talking about remote robotics. We've not reached that point in brain surgery anywhere at the moment. They're trying. I think they've done a couple of spinal operations remotely, but I don't think anyone has attempted a brain operation yet. But then what I was talking about was when you have the scans of the patient, you can use virtual reality to recreate the scan in 3D space, and you can see the relationship of the tumor to the different nerve tracts in the brain and plan your approach virtually, so that when you actually do the operation, it becomes much easier. You know what to expect. So we used to do that quite a bit. In India, obviously, you've got to take into account the financial equation because the government cannot afford to pay for the healthcare of everybody in the country. I think here it is driven by cost. So not everyone can afford the cost of advanced neuronavigation aids. You have to counsel the patients for it, and if they agree, then we use it.
So when you say about the advanced therapies, like all the hospitals will have the same kind of facilities, or a specialized group of hospitals, or like a bigger hospital setup will have this kind of.
Are you asking about the UK or India?
In India.
In India, right. Well, I mean, most of the hospitals you would expect to be corporate giants, for example. You would expect them to have it. Obviously, I've not toured all of the large hospitals to know for certain, but Kauvery certainly has all of the advanced aids, and we certainly do use them in our patients, as I said, when it is financially affordable for them.
So when it compared to the earlier stages with the different mode of surgery and therapy and current new strategies and technologies, so how the outcome of the patient has been changed? Is it improved, or is it as much better? How is the outcome of the patient?
Well, I hardly need say that with technological advances, outcomes obviously are much, much better, to the point that previously when I say previously, I mean about 20 to 30 years ago. If people needed a neurosurgical operation, it meant they gave up on the desire to live and came into the hospital thinking they're certainly going to die.
Yes.
And if they improved and they went home, then that was a bonus. We've brought that now to the point where patients actually look disturbed when they hear a 2% or a 5% rate of complication for an operation, which is a great thing because obviously people are expecting to have good outcomes. We're delivering them consistently, persistently, and I think the technological advance is vastly helpful for that.
Okay, so when you say the advancement is very good and there is a lesser chance of complication, but for a patient and their families, when it comes to brain surgery, as I said initially, it will be overwhelming and they'll have a lot of fear. So how do you counsel them to understand, like, okay, this is the risk of surgery. If you are not doing, what is the risk, and how you make sure that the importance of surgery is there, or how you make sure that the patient's doubts are cleared?
Right. This is purely personal opinion, obviously, because there is a wide variation in practice about how people approach these things. For me, I find that we underestimate patients and their relatives. They have a lot of strength, mental strength. They have a lot of ability to absorb information. And previously, we might have been guilty of not giving them enough. I believe in blunt honesty, but not so blunt as to make them scared, but enough that they know we are always going to be speaking the truth.
Okay.
And it is a very, very important point for the patients to trust that you will always be truthful to them and never, ever lead them astray. And I think when you start off with that base, you set the expectation that you will always be honest with them, things suddenly become much easier.
Yes.
They listen better. They take in what you're saying. And when you explain to them the relative pros and cons of having surgery versus potential complications, they're actually highly astute.
Yes.
Even people who we think are maybe they haven't had the opportunity to be educated or even they are extremely intelligent in absorbing this information.
So that means the patient family also understanding the risk and they are ready to take the risk and continuing the surgeries and treatment.
Well, I would think I would couch it in a slightly different way, which is they're not taking a risk. What they're doing is understanding that there are potential risks and complications with every operation. They're beginning to realize that surgery is not a magical cure, and they are beginning to accept that it is part and parcel of the process. And what they're looking forward to instead is the larger chance of recovering and getting better.
Okay.
I think the most important thing I'm beginning to realize is patients are now coming to terms with the fact that doctors can't wave a magic wand and make everyone back to normal like they were in their 20s. I think that is disappearing, and that is a good thing.
Okay, because most of the patients now Googling everything and they are finding out each risk and each of the complications, outcomes, everything.
Absolutely.
So that makes it more riskier for you to counsel the patient and get the things done.
Absolutely. I mean, while you're counseling patients, the important thing is not to downplay or be condescending to their concerns. You have to meet it head on, and you have to tell them directly. And as I said, openness, honesty. You have to show that you are actually listening to their concerns. You're understanding the problem. You are acknowledging the anxiety, and you're answering that. You're not skirting around the issue.
Yes.
I think patients instinctively realize when you're dancing around an issue. If they ask you, doctor, is there a chance I'll be paralyzed after this operation? And you keep saying things like, oh, you have to look at how how we can take the tumor out. Patients are not idiots.
Yes.
They are very, very smart, and they know when you're dancing around it. They'll just pin you down. What you should do instead is honestly say, yes, I mean, when I do this, there is a chance that there might be some weakness, but we expect it to be maybe most of the times temporary, but there are chances it can be permanent. And that is, I can do nothing to take that away. And when they realize you're telling them the truth, they just go, okay, fine, let's do it.
I think giving them the real expectations and real outcomes will make much more easier than going around with or dancing around in something else.
Absolutely. It takes too much effort as well.
Okay. So, doctor, when it comes to spine-related things, like both tumors and degenerative issues are increasing day by day. And when it considering to a patient, when a patient should consider this as a problem, or when they come to a doctor for seeking a surgery or for a treatment plan.
Okay, well, I mean, I think um, one of the issues with spinal conditions is there's a lot of pain involved, back pain or leg pain, things like that, both tumors or oncological problems as well as degenerative problems present similarly most of the time. There are subtle differences in the way they present. One thing I would say is in terms of pain, back pain is very, very common. It has a lot to do with biomechanical stresses, the way we lead our lives. With that, I mean commuting in heavy traffic with bad roads, posture while you're working, sitting for long hours on end, having neck positions which are not suitable anatomically or physiologically. Those cause a lot of long-term problems and they cause a lot of pain. But when you have pain, if it's related to action or movement, that may correspond to degenerative conditions generally.
Okay.
But the one thing I would say about pain is if you're having pain that wakes you up in the middle of the night or doesn't let you sleep, that is a problem. You need to get it seen promptly.
Yeah.
So people need to know some of the subtle differences. If you start having neurological issues, don't ignore it. If you're tripping over your own foot, if your foot is flopping down, you're unable to pass urine properly, you're unable to pass, motions, or you suddenly develop a numbness in your private parts, that is a red flag. Please seek medical attention straight away. Those are the things, patients need to know.
Because when it comes to most of the patients, like we had seen many patients, like they will not take a proper treatment in the initial stage.
Yeah.
They'll keep waiting, and they come to a doctor in the final stage, and the doctor will also be a person who will have to take a more risk than if the person comes an early diagnosis or early treatment.
I found that most of the time that is because people are scared of a diagnosis. They're scared of finding out what it might be. And they tend to avoid it. And I think we're all personally a bit guilty of that as well. Sometimes I don't like to, because I know this might lead to something big and I tend to avoid it. And then we have to keep reminding ourselves there is no point ignoring it because it's your own health. And the more you ignore it, the worse it's going to get eventually at some point. And it may be beyond our capability to help. So I think that's important.
Yeah. So when it comes to the modern lifestyles and working conditions, like we see most of the persons are getting obese, or when they're working in IT, they have to sit for a longer time and they have multiple complications. But most of the persons are aware of these things, but they are not taking any precautionary measures to prevent this. So what's your advice for them to correct these things?
Well, I think considering that I work in Electronic City and most of my patients are IT professionals, I think we've realized a few things. One of them, I love this thing. The position they normally adopt is that of a prawn. They're sitting there hunched up, using a keyboard that's high, and they're craning their neck constantly, or they're lying down on beds in upward positions. I think it's all very well when you're in your 20s and you do that for about a year or so. That's okay. Your spine will forgive you. But as you cross the threshold into 30s and 40s, it'll start punishing you because the spine does not like awkward positions. It has to work a lot harder. Your muscles in the spine, which are small, mind you, postural muscles are not large. They're not like your gluteal muscles or your leg muscles. They are small and they need a lot of energy to keep you in a good posture. So if you're in a good posture, they don't draw as much energy because that's what they're designed to do.
Yes.
If you're in an awkward angle, they draw a lot of energy and you get a lot of pain. And eventually you will start developing compensated degenerative changes because of those angles.
Okay.
So what I always suggest to my IT patients is the sitting position during the day. You have to try and be as mobile as you can. So after you work 20, 30 minutes, you get up, walk around for 2 or 5 minutes, stretch yourself gently, come back and work again. And when you're sitting, get yourself an ergonomic office chair which can support your back, allow your neck to be held loose and relaxed. Keep your computer screens at eye level. I don't want anyone to be looking down on the screen. They should be looking at it at eye level. The other thing is if you can get a standing desk, you use that. Stand up and work after about half an hour of sitting. I think these are basic things you can do to protect your spine. And the other thing then is have some sort of an exercise habit.
Okay.
Cultivate an exercise habit to keep yourself strong. I think that is so. And you touched briefly on obesity. I think that is another problem. Without going into great detail, I would say try not to get into the vortex of becoming obese, because that is a real problem.
Okay. So when you said about exercise also, nowadays, like there is a trend like either you will overeat or either you will be more concentrated on exercise. So when you say about exercise, the persons who go to gym, they want to build up their muscles in 1 day or 2 days. So the way they lift up their weights, like suddenly from 1 kg, they'll go to 10 kgs to 50 kgs. So that will again strain the spinal cords and everything. So how do you manage that kind of situations?
I think that is a topic that's actually rather close to my heart, because I like going to the gym myself, and I've had the habit for about 20 odd years. I think what's important to realize is doing any form of exercise, and especially the evidence is in favor of resistance training or strength training, not lifting weights merely.
Okay.
Anything that can increase the strength in your muscle. I think the evidence lies there. It protects your joints, it protects your bones, it protects you from aging quicker.
Okay.
And we know that it prevents shortening of your DNA as well. So it does prevent aging. The way to look at it is it has to be a lifelong habit. Just like you eat meals, you read what you like, or you go to the toilet. Going and exercising has to be the same way. Find time in your day at some point for 20, 30 minutes. The minimum exercise you need every day is 20 minutes.
Okay.
That is all, nothing more. You don't have to go about lifting 200 kilos. Nobody says that.
Okay.
You just have to have some resistance bands and do that, or do certain difficult yoga poses. That is more than enough.
Okay.
Start small, be consistent.
Okay.
That is all I would say.
Okay. So when it comes to the surgery part, so what are the latest minimally invasive spine surgery techniques available today? If you tell me in a short things like.
Certainly, I think we've moved on from the previous large open wounds. I think we've moved through the era of minimally invasive spinal fixations, for example, using X-ray techniques, to then using what we call the O-arm or the C-arms, to have a scan of the patient, and then using image guidance to put in these pedicle screws and do the advanced operations. And now we're progressing even further to using endoscopic techniques, where you use either 2 ports or a single port, and you can do many, many things endoscopically. Some of the world leaders in endoscopic spine surgery do most of the old spinal operations completely endoscopically these days. But I think the vast majority of practice is somewhere in between. We have adopted some endoscopic techniques. Some of them are still better when you've done it in the open way.
Oh, that's great. So when it comes to the treatment part, because there will be 2 types of management. One is conservative treatment and one is surgery.
Yeah.
So how do you take a decision like the patient requires a conservative management or a surgical management?
Well, now you're going to the basic of surgical practice. I think one of the very first lessons Dr. R.M. Verma said was, Harsha, you don't become a neurosurgeon when you know how to operate. Monkeys can be taught how to operate. The important question is, when do you operate?
Yes.
Okay, that is the basic principle of surgical practice. So it would have to be a coalescence of different factors, patient factors, surgical factors, whether you have the expertise to do that or not. Most of it is to do with the patient, the condition, the disease, the imaging, the symptoms, the expectations, they all have to match. If you cannot match them all, you shouldn't be operating.
Okay.
That is in a nutshell. Obviously, it's more nuanced than that, but yeah.
Yeah. So when you say about the patient, like it's making a timely decision rather than delaying the treatment. So if they come in the correct time, they'll get an actual treatment in a well-managed way.
Absolutely. I think even if you say it's not an emergency operation, for example, if they come early doors, then you can tell them we have time to plan this. We can wait and watch. And if things progress further, we can operate. but then you already have a plan in your mind. If it gets worse, this is what I'm going to do. And I normally tell my patients, if this progresses along this line, this is what you might expect. I think that prepares them ahead of time.
Okay. So the other specialty what you do is peripheral nerve conditions. Like when as a normal patient, as a normal layman, like they don't understand like what do you mean by peripheral nerve conditions, and how can you understand when there is a disease condition or not. So can you please tell how can they identify, or how can they understood that there is a kind of disease condition like that?
So peripheral nerve surgery is again one of the subspecializations in neurosurgery, and it is a challenging field because peripheral nerves are not like tissue in the brain or in the spinal cord. They don't give you a lot of leeway, and most of the time peripheral nerve surgery is limited to compressions or certain times trauma. Now, trauma practice in peripheral nerve surgery is not widespread. We don't do that, mainly because it needs certain very specific instrumentation and machines that not everyone invests in. But when you talk about compressions, for example, in the wrist or in the ankle, in what we call the ulnar nerve or the funny bone in the elbow, those decompression operations, when you start finding that you're having difficulty holding up a phone, or when your fingers start tingling, we do some electrical nerve tests, and if they show reduction in the transmission of impulses in the nerves, we decide that those nerves need to be decompressed, and they can be done either endoscopically or open operations. So it's a wide field.
So when you say about the nerve conditions, so what are the most common nerve conditions you see with these kind of disorders?
Oh, you mean in peripheral nerve problems? By far the most common would be the compressive problems like median nerve compression, which we call in common parlance carpal tunnel compression or carpal tunnel syndrome. And you also have something called ulnar nerve compression, which happens around the elbow, where you have problems with the hand again. Or you can have peroneal nerve compression around the knee, when for example, you make a bad turn or a hit against your outside of the knee, when you're, say, playing football, someone kicks you, then you can get a drop foot. That is a peroneal nerve injury, which might need an operation like a transplant or a graft, and things around the ankle as well. Again, compressive pathologies, tarsal tunnel syndromes. It's wide-ranging, various, and quite fascinating.
So when you say about the surgery, so after the surgery, can they regain their full function after surgery, or is there any minimal reduction will be there in the functions?
I presume you're talking about peripheral nerve surgery again. So most of the time, except for carpal tunnel compression, most peripheral nerve surgery, especially when it's for example, brachial plexus injuries, there is always going to be some limitations after an operation. And that is where the role of rehabilitation comes in, because peripheral nerve injuries, especially with good rehabilitation, specific focused physiotherapy, you can have a much better outcome than not. So I think the operation is only the beginning.
So, doctor, when it comes to another specialty, you have treated many pediatric patients also.
Yes.
So, when you treat pediatric patients and adult patients, so what is the major difference you had seen compared to the treatment modalities, or when you treat a pediatrics or an adult patient?
There are a few things. I mean, first off, there is a myth that children are small adults. That is an absolute myth. Children are not small adults. They are a separate physiological class by themselves. They behave completely differently. Their systems are different, and you have to treat them differently. Most of the times in pediatric populations, what you find is congenital problems or defects of the DNA or chromosomal defects that cause certain things. Like, for example, I specialize in dealing with spinal cord abnormalities called dysraphism, where children are born with spinal cord being exposed to the elements, where we have to close it and try and regain some function. And there are other various aspects to it. And then some of the tumors in pediatric populations are entirely different to adult tumors. So it's a completely fascinating separate field to study. There are some skull abnormalities we have to deal with where the skull fuses early and you've got to release it to allow the brain to grow. So again, all of these are entirely different. But happily, children are wonderful patients. There is no putting on symptoms. There is no acting. There's a medical term called malingering, which is very common in adults, but it doesn't happen almost in children. They're either unwell and you can see that they're unwell, or they're well and they're off to play, or they want to do their own thing. It's wonderful. So kids are very different that way. And also in terms of rehabilitation, when you apply good rehab principles in children, the rewards are much greater because they have much more compliance, much more of a desire to do activity because they are naturally active, and their tissues they have much more resistance to injury. So they recover much better than adults do.
So either way, again, when it comes to pediatric patients, family or the parents, so they are again, they need your guidance, supports, and emotionally counsel during the entire part of treatment. But again, when it comes to an adult counseling, it will be an entirely different challenge, and when it comes to pediatric counseling, it is an entirely different thing.
Yes.
So what is the main differences between them, and how do you counsel the patient or parents to take care of the kid with the proper surgery and other treatments?
Again, it's a very nice question. I think with adults, obviously, they are capable of understanding what they are going through. You can explain to them their own disease process and they understand. Some of the children, don't get me wrong, they're very switched on, they're very, very alert. And especially if they're teenagers and things, you can certainly explain to them. But I think, as you said, parents, as I'm a parent, I am fine if something goes wrong with me because I know I can handle it, but I'm petrified if my daughter has a problem. That is a normal human reaction. As long as doctors understand that parents are just scared for the child and they don't know what's going on, if you establish a rapport with the child, you will see parents relaxing. Then you can counsel them much better. And then the counseling is the same as you would if it's an adult patient. It should be because they know if you get on with the child, you're going to look after it, you're going to look after the child well. That relaxes them instantly. I think that's the critical thing.
Okay. So when you say about rehabilitation and recovery, so one aspect that is often overlooked is like what happens after surgery, and like from your perspective, like how important is a rehabilitation for a spine and brain recovery or after surgery? How they have to go for rehabilitation treatments?
Well, I don't think we even need to talk about just my perspective because it is evidence-based. There are enough papers across the globe to say that early rehabilitation is critical. It improves outcomes. It makes people get a much better recovery towards normalcy. I always say to patients, when you need neurosurgery, it means that there is something deeply wrong with the nervous system. You're already vulnerable to problems, and rehabilitation should start immediately after the operation. So the aim is to mobilize them as soon as possible, start training them in whether it's brain operation needing speech and language therapy or occupational therapy or aggressive physiotherapy. And the term is aggressive. It has to be hard. If patients don't complain about the physiotherapist saying they are really giving me, they're making me tired, then it's not effective.
So what happens if a patient delay in rehabilitation or if they're not taking rehabilitation post-surgery?
I think increasingly we're beginning to realize that the sooner you start rehabilitation in a structured manner, the better the outcome is going to be. So what you're looking at is if you delay rehabilitation, say for example after a stroke, and you delay rehabilitation by say 2 months or 3 months, I think the outcome is going to be just as bad as you never doing rehabilitation. I think that is the basic point.
So when it compared to that, like then how soon they have to start a rehabilitation therapy?
As soon as they are medically safe to get up and about. If they are not cardiovascularly unstable, if they're not having an unstable neurological problem, they should be mobilized immediately and they should be helped.
Okay, so because many of the patients are unaware of the rehabilitation treatment and what physiotherapist or a speech therapist or an occupational therapist do, like, so how can we give an education to them, like what is their role and how they will help in like recovery after surgery?
So I think we start talking to patients. For my practice, I start talking to them about rehabilitation and physiotherapy as soon as they come in. For example, someone with a spinal fracture and a spinal cord injury, as soon as they come in, I say to them, you've got a spinal cord injury, we will operate to fix the fractures, but the spinal cord is something that will take time to recover. And the only way you're going to help that is by engaging in rehab. And we explain to them that it's critical. We start showing them the passive exercises, the active exercises that they can possibly do. And I think what will help is if we get our rehabilitation colleagues to come over while the patient's still on the ward, see them, provide a session of counseling for about, I don't know, half an hour to 1 hour, take them through what is going to happen in rehab, and then put them at ease. The seed of this idea has to germinate in the patient's mind, and they should know that that is the natural process. They've come into hospital with a serious injury, they get an operation or not, and then they go to rehab. That has to be the pathway in their mind.
But when you see like well-developed cities like Bangalore, also there are many hospitals, but there is a lack of rehabilitation center in many places near to hospitals.
Yes.
Yes, definitely there are many places are coming up, but still there are a lack of many rehabilitation centers, and the hospitals will not allow any other outside rehabilitation centers persons to come in to see their patients. So in such scenarios, like how they can come to know like what are the things they do in a rehab center, or how can they understand how it will be beneficial to a patient?
Well, I think that's a sort of that's going into slightly politically charged discussion points. Obviously, at least in Kauvery, we don't believe in restricting patient choice. Kauvery has its own rehab center in Manathalli, but still, my patients get a choice. They get to visit other rehab units, the relatives at least. They make up their own minds. I always invite my rehabilitation colleagues to come and see them in the hospital. None of the management have ever stopped them. We believe in an open and honest environment. I think more hospital management makes a large difference. Our medical director is really, really friendly. He is very approachable. Our CEO is extremely open about patients getting the best. Whether it's in Kauvery or outside, we want the best for them. So that way, I think I would encourage most of my corporate colleagues to take up the same practice. Your patients deserve the best. Give them the option.
Yeah, because in the end result, what we are looking is the patient outcome, and if they get better as a surgeon or a doctor, we will also feel much better. Yes, after the surgery, the patient is getting much better.
Absolutely. I would say that. I think that would be in the spirit of a patient-first approach.
Yeah. So that means to say that the recovery doesn't end with surgery, but it actually begins there, and proper rehabilitations plays a crucial role in recovery and progress.
Absolutely. Especially when it comes to nervous system problems.
Okay. And when it comes to choosing a rehab, so what are the things the patient or patient attendant has to keep in mind when they go or visit a rehab center or something like that?
Well, that depends entirely on the condition we're dealing with. And that is where our role as guides and mentors, that comes into play. You know, if a patient has a tracheostomy after a stroke and things, then the rehab center needs to have certain facilities like you've got to look after, your doctors have ICU credentials. That would be critical in looking after someone with a tracheostomy. And so if someone has to recover from a stroke, then you would need to have physiotherapists who specialize in stroke management. It is not simple. To recover from spinal cord injuries, you need to have certain equipment, a well-equipped gym to get their strength back up. You need to have physiotherapists who understand the spinal cord. That is what you need to look for. I think care is individually tailored. Every patient will have different needs. You have to assess that and then work out on the basis of that which rehab center would be best suited to look after them.
Okay. Okay, doctor. When it comes to future trends, like what are some of the exciting advancements shaping the future of neurosurgery?
Oh goodness, I think we'll need a 3-hour monologue on that. Exciting developments. I could talk for days even. I think in a nutshell, I think brain surgery. I think the exciting days ahead are the use of AI in mapping, for example, tumor surgery, helping us map tumors better, helping us devise safer pathways and minimizing the surgical footprint. In spinal surgery, I think, again, image guidance and robotics come into play, as well as the advent of endoscopy and the use of the combining of image guidance and endoscopy. That would be one thing. Pediatric neurosurgery has the same advantages as adult, which is the same equipment would be used. But I think the advances equally are exciting in the field of rehabilitation itself. Advanced therapies, the understanding of how recovery works, and the utilizer, for example, the exoskeleton being used in spinal rehab, for example, it is a leap forward. And I think things like that, they are really exciting and something to look forward to. Yeah.
So when it comes to, as you said, like AIs and other robotics, so are these technologies becoming a part of routine practice, or it still need to evolve more?
I think there is always a danger of getting too far ahead of yourself sometimes. You need to slow down for a breath and say, use them when you see that it fits into the care you're providing. There is always the danger of throwing out old things just because they're old, and I think that is the wrong way of looking at it. The old techniques have their own roles, but I think you also have to welcome advancements, and technology is here to help, and that is how we should use it.
Okay. So when it comes to an awareness and early diagnosis, so what are some of the warning signs related to brain, spine, or nerve conditions that the people should never ignore?
So if you're a normally healthy person who doesn't suffer with many daily problems, anything out of the ordinary, people have an instinct about these things, something that feels out of place, something that is very abnormal. For example, you start suffering with headaches almost on a daily basis after having never had headaches all your life. That is a red flag. Why would you ignore it? Things like, as I said earlier, back pain, when it wakes you up in the middle of the night, that is not normal. Nobody would think it's normal. Losing control of your urination, for example. Pain shooting down like an electric shock whenever you bend your neck. Losing balance, walking like a drunk person when you don't drink at all. When you not feeling the pain and having burns where you've never even realized it. Those things are not normal.
Yes.
I mean, I certainly don't think so. I hope everyone agrees with me on that. When the more subtle things would be behavioral changes sometimes. People present with, oh, he's not the same person I knew 2 years ago. But that is a red flag, actually. People just don't change after they become adults.
Yes.
Children might grow into different adults, but adults don't change their nature.
Yes.
So if you know someone really well and suddenly you think, actually, over the last 1 year, you've really changed and it's not for the better, you have a problem. Get it seen, get it looked at.
Yes.
Elderly people suffer with a condition called normal pressure hydrocephalus. They have behavioral changes, balance problems. They start, losing control of their bladder. That is when you should get them seen.
Okay. So how much difference does early diagnosis make in outcomes?
Well, it's a linear relationship, isn't it? It's a direct relationship that the earlier you can diagnose a problem, the better it is. I mean, we have lessons from lung cancer treatment and breast cancer treatment. You diagnose them before it spreads anywhere, you can catch it early, their life expectancy would be more than 10 years.
Yes.
You catch it when it's spread to the liver, lungs, spleen, and what have you, they're dead in 6 months.
Yes.
Similarly, with neurological illnesses, if a neurological deficit or a problem becomes fixed, we won't be able to do anything about it. But when you have the early signs, and this is why we say, even in strokes, time is brain.
Yes.
As soon as you start noticing your face is drooping a bit, your arm is not lifting up, get to the hospital or get someone to take you to the hospital.
Yes.
then we might have a better outcome.
No, but yeah, most of the patients, as you said earlier, also like they'll keep waiting. Oh, it is just a normal thing, just a normal thing, unless until they realize it's a real emergency. Like they have to
Yeah.
rush back to a hospital.
Well, that is where government support comes into play. They have to have educational campaigns. They have to run, awareness campaigns all over media, print, digital, TV. People should know what they're looking for. The main headlines. You have this acronym called FAST for a stroke.
Yeah.
The face, the arms, speech, and tongue.
Yes.
If someone sticks their tongue out to the side, or they have a face drooping, or their speech suddenly gets garbled,
Yeah.
or they have an arm weakness, those are the things you don't ignore.
Yes.
And similarly for other things as well.
Yes. So when it comes to a treatment, can you share any case which is handled by you where the timely surgery and proper follow-up made a significant difference in a patient life or an outcome?
Oh gosh, I mean, I would have to rack my brain through many cases, but I think uh, I would keep it general rather than a specific case. I think most of the times when I deal with malignant brain tumors called malignant gliomas or glioblastomas, they are the nastiest of brain tumors that we deal with.
Okay.
And the earlier you pick that up, the better it is. So if you pick it up when it's a small speck and you operate and you take it out entirely, because outcomes are directly related to how much I can take out safely.
Okay.
And these tumors spread by the weeks and months, not by years. So if you delay diagnosis by a month, it makes the difference between having a successful operation and cure versus me being unable to treat it at all. So yeah, every time I've picked up a malignant glioma in an early stage when the tumor is small and it's contained within one part of the brain, the outcomes have invariably been much better
Okay.
than when they come in with a large tumor spreading everywhere, that sort of thing. Yeah.
Okay. So I want to have some rapid fire questions to you so that I need
Okay.
some quick answers. So one symptom like the people should never ignore from a neuro perspective.
That would be very difficult to answer because it's very, very generic. But I would say anything like a sudden alarming headache, sudden severe headache, like a blow to your head, or a sudden neurological deficit, sudden neurological symptom, don't ignore it. Sudden abnormal amounts of pain, don't ignore it.
Okay. Okay. So one myth about brain and spine surgery.
Well, the myths are on both sides, which is if you have a brain or a spine operation, you're never normal again. That is a myth. You're almost certainly going to die if you have a brain operation. That is a definite myth.
Okay.
Because the outcomes are in 90 to 95% of cases, you actually do very, very well and you come back to somewhere near normalcy.
Okay. So when it comes to like recovery, what is the biggest misconception?
When it comes to recovery, I think people miss the point that in neurosurgery, there is the concept of disability because other fields deal with life and death.
Okay.
So people tend to think as soon as I have the operation, my risk of death is avoided, I'm normal again.
Okay.
In neurosurgery, that just doesn't hold good.
Okay. So one tip for faster recovery after surgery.
Engage in rehab very, very early doors, for heaven's sake.
Okay, so I think there are valuable information provided by you. So before we close, like what would be one key message to the patients and families dealing with these kind of neurological conditions?
I think the one key message would be don't ignore red flags, don't ignore major symptoms and signs. Come in as early as you can. Don't be afraid of a diagnosis. Don't be afraid of the process. We are here to guide, help, and offer whatever assistance we can. We're not going to let you face problems alone.
Okay.
But all of the hard work will have to be done by the patient because they are the one who has to recover.
Okay.
So I would say come early, get diagnosed, and opt for good treatment.
Okay. Thank you so much, Doctor, for sharing such valuable insights with us today. So this conversation, I think it has clearly highlighted what's the surgery modalities, how the treatment plans has to be, and how the recovery has to happen with a proper rehabilitation plan. So I think the viewers will get a clear idea like what are the main disease condition they go through and what are the symptoms they have to check in or when they have to consult a doctor for the treatment and everything.
Absolutely. It was my
So,
pleasure. Thank you for having me.
Thank you once again for joining us, doctor.